Okay, are we having fun yet? Next is inflammatory bowel disease, also lower GI. Unlike irritable bowel, inflammatory bowel disease is a chronic inflammation. It is recurrent in the intestinal tract. There's no cure. The exact cause is unknown. And remission is important to understand with pharmacological considerations, but then exacerbations occur with flare-ups, etc. But it is very different from irritable bowel syndrome. So to understand the classification of inflammatory bowel disease, there are two subcategories, which would be, or two subdiseases, which would be ulcerative colitis and Crohn's disease. They are based off of clinical manifestations, which one those diseases are. And I'll go into that a little bit further in this presentation. The inflammatory bowel disease can occur at any age, onset between 15 and 25 years. Important to note for gerontological considerations, the second peak is in the 6th decade. So the person with the condition might have the disease all lifetime, right? And then they have they have remission, and they have exacerbations, but then they really have a huge peak of the disease in that gerontological time period. It equally affects both genders. Now, it is also an autoimmune disease. And what do we know about the autoimmune disease? What other diseases have we learned about this semester that are autoimmune? Let's take rheumatoid arthritis. So what is the autoimmune? The body is doing it to itself, right? So this particular one, as in rheumatoid arthritis, it attacks the joints, right? This particular one attacks the intestinal tract. It involves a combination of factors, environmental factors such as diet, hygiene, stress, smoking, non-steroidal anti-inflammatories, increases susceptibility because that changes the microbial flora, the immune system. IBD is more prevalent in industrialized regions of the world. No known if diet and other factors unique to Western countries contribute so Western versus Eastern areas or countries unknown. Specific dietary components have not been identified, like for example, like with irritable bowel, the FODMAPs. However, high dietary intake of total fats and meats are associated with increased risk of inflammatory bowel disease. High fiber and fruit intake associated with decreased risk of Crohn's disease, but vegetable intake is associated with decreased risk of ulcerative colitis. There's genetic predisposition, more common in Caucasian, particularly those of Jewish descent. But as far as genetic predisposition, so this suggests that inflammatory bowel disease is a group of diseases. And then, of course, the alterations in the function of the immune system. But we talked about that. So what are the risks of the alterations of function in the immune system? Well, we know that if we have decreased immunity, then different pharmacological therapies might be needed if someone has an alteration of the immune system. Let's see. So the pattern of inflammation, just comparing the two side by side of Crohn's disease and ulcerative colitis, you can see the different areas more prevalent in the intestine. With Crohn's disease, inflammation can occur in all layers of the bowel wall, but it most often is in the terminal ileum and colon. Some of the clinical manifestations: diarrhea, bloody stools, weight loss, abdominal pain, fever, fatigue. So that certainly differs from the irritable bowel syndrome, where the irritable bowel syndrome might have diarrhea or constipation, just chronic discomfort, bloating. The inflammatory bowel disease really has the bloody stools, weight loss because of nutrient absorption, fever, if there's infection, um, fatigue, more from the malabsorption. So the GI tract complications, hemorrhoids, excuse me, hemorrhage. Hemorrhoids can be a complication as well, but specifically hemorrhage because of the bloody stools, any ulceration with that inflammatory bowel. And that can lead to further complications such as anemia that needs to be corrected with transfusions, iron supplements. Now, strictures or fistulas can occur, and that can cause infection, can cause other organ system clinical manifestations. And there's another slide on that I'll show you in a minute. So some further complications, for example, with ulcerative colitis, with Crohn's, with inflammatory bowel disease, when you have this chronic inflammation, chronic irritation, or even ulceration, high risk for colorectal cancer. So those particular patients are at an increased need for having colorectal screening and more frequent colonoscopies or diagnostic studies to screen for cancer. Systemic complications. So this is from the chronic disease. Circulating cytokines trigger inflammation. So the systemic areas that are more prevalent to inflammation, such as the joints, eyes, bone, vascular areas, that occurs. So liver failure is another complication. So what would be important as a nursing intervention to monitor for these? Well, of course, the colonoscopy for regular screening for colorectal cancer. You're looking at immunity, blood counts, metabolic panels. Specifically to screen for liver failure, you're looking at routine liver function tests. So what can happen let's further talk about this inflammation and strictures. So let's first talk about the pattern of inflammation for Crohn's disease. So there's strictures at the areas of inflammation. And so these strictures, or the bottleneck, if you're thinking about a freeway or plumbing situation, that can cause bowel obstruction because the bowel is not able to empty correctly, or that inflammation is causing a blockage. Then the inflammation can go through the entire wall. So then you can have bowel content, microscopic leaking into the peritoneal cavity. And of course, the peritoneal cavity is not supposed to have bowel in it, right? So abscesses form. Peritonitis can result, so you have a major infection. Further problems, fistulas can develop, so those are these tunnels, right, between the areas. Now the problem is then feces is leaking through these areas. So if the adjacent areas of the bowel, the peritonitis, between bowel and bladder, you could have frequent infections, urinary or cystitis infections of the bladder. Between bowel and vagina, then you've got infection in the vaginal area, you've got foul odor. And unfortunately, fistulas can also form through the skin to the outside of the body. So these patients, there's body image distortion if you are smelling like feces on your skin. So some common symptoms: diarrhea, crampy abdominal pain. Of course, we talked about the rectal bleeding. Now, those are the common symptoms. Less common, weight loss from this when the small intestine is involved, rectal bleeding, fever, or other systemic symptoms. So that's great for the Crohn's. So those are less common. The rectal bleeding is more often in ulcerative colitis. But weight loss can occur in both from not absorbing the nutrients or from malabsorption. So now let's go to ulcerative colitis and the pattern of inflammation. So the colon and the rectum. This is now ulcerative. Think ulcer, right? So what's the ulcer? It's the erosion of that that area, the intestinal lining. So obviously you're going to have inflammation. You're going to have that ulceration. Diarrhea with large fluid and electrolyte losses, breakdown of cells, inflamed mucosa. That ulceration can cause these pseudopolyps. The common symptom we talked about, bloody diarrhea, and the problem from several to 20 times a day. So think about how that impacts somebody working, how that impacts daily life. So in severe forms of the disease, fever, rapid weight loss. So think again regarding nutrition. Anemia from the blood loss, tachycardia, dehydration from the volume loss or the fluid loss. So a big diagnosis or a big consideration when you're diagnosing for irritable bowel, or a patient is going through the inflammatory bowel disease diagnosis, is ruling out other conditions. In early Crohn's disease, the symptoms are similar to that of irritable bowel, where you've got the bloating and irritation. Now, these diagnostic studies, CBC for anemia, serum electrolytes, serum protein levels, that's all for understanding the nutrition or protein loss through the ileum. Stool cultures are important. That's just to determine if an infection is present. Imaging studies, colonoscopy examines the entire large intestine. The other scans can look at the extent of inflammation, especially for the small intestine. And for goals of treatment, so because the cause is unknown, you're treating with drugs, you're treating with trying to help with symptom management. So resting the bowel helps, and that means NPO, that means no food. They're going to get nutrition elsewhere until so they can rest the bowel. Then control inflammation with medications. If there's an infection present, you're obviously going to treat for that. Any malnutrition, you're going to want to correct for. And the other factors that can contribute to your immunity, alleviating stress, and of course the goal is to improve the quality of life. Now your medications, aminosalicylates, you're treating for inflammation, antimicrobials if an infection is present, corticosteroids for inflammation. What's the downside for corticosteroids? Immunity, or even gastritis, infection. You're taking precaution when you're using this drug therapy. Immunosuppressants, remember autoimmune, but again, of course, problems with infection, and you have the side effects from those medications. But the goals of the drug treatment is to have a remission and for supportive care. Nutritional therapy, these patients are really going to need dietary consult to understand their nutrition because they might have malabsorption. They might be on other supplementations. So in addition, the medications can contribute to the nutritional problems. So the patient has malabsorption because of the actual disease, and then the medications to control the symptoms of those disease can further lead to nutritional problems. So you can see on this list some of the areas that you're needing to take into consideration when treating with those medications. Foods that trigger exacerbations really vary. So just like irritable bowel, the food diary is really helpful because these foods that trigger exacerbations may be very different from patient to patient. Worst case scenario, the patient needs surgery to remove or correct the strictures, correct the obstructions, help with the bleeding, or remove the ulcerative area, or correct for the fistula. Furthermore, this surgery might be to decrease or to remove the affected bowel. So a worst case would be the patient needs an ostomy, but either way, the patient's going to need nutritional support with any surgical intervention. So during the acute phases, the nursing management, you of course hemodynamic stability, pain control, fluid and electrolyte imbalance, nutritional support, manage fatigue, maintain skin integrity, deal with odor issues like I spoke about if they have fistulas in areas, or they have an ostomy. Think about those nursing considerations. And again, the goal is to decrease the number of diarrhea stools, maintain the body weight, use effective coping strategies. Specifically for gerontological considerations, look at this, again, we talked about the second peak. Because gerontological patients have considerable other conditions or comorbidities, the diagnosis can be difficult. It might be confused with C. difficile if the patient was on prolonged antibiotics. And then colitis associated with diverticulitis or NSAID ingestion. And then they have a greater risk of complications for treatment if you're using corticosteroids on somebody who's already osteoporotic. Those are the factors that you need to consider for inflammatory bowel disease. Thank you.